Alright, so we're going to start talking about the shoulder today. As with most things, we'll start with just bones. So your shoulder is comprised of a few, three primary bones: your clavicle, your scapula, and your humerus. Your clavicle, or also known as your collarbone, everyone kind of knows what that is, right? So it has two different ends. You have a sternal end and an acromion end. Pretty simple if you break it down. The sternal end articulates with the sternum. The acromion end articulates with the acromion. So then you can talk about your scapula. You have costal and dorsal surfaces, vertebral and axillary borders, and inferior and superior angles, which I'll show on this next slide here. So the ventral side is looking at it like from the front, like if you were to imagine like on my back. My scapula's here, the ventral side is my palm, or the essence, and then the dorsal side is the back part, which you can kind of touch on your shoulder. The spine of the scapula is this guy right here, this number 1, that kind of goes across. You can feel it on someone else's, like on someone's shoulder blade. You have the acromion, which is this little projection here, which attaches up, which is where your collarbone and your acromion meet, make up your AC joint, which we'll talk about in a little bit. You have your borders all around. You have your supraspinous fossa and infraspinous fossa, which are just these little spaces in between on this bone here. Pretty simple if you break it down. Is where the supraspinatus muscle sits and where the infraspinatus muscle sits. You have your medial and lateral border. Pretty simple. The medial is on the inside border here, and the lateral is on the outside. And that's pretty much just the stuff that I really care about. All the other stuff is more or less my famous appreciation slide of just kind of what else is going on and how many landmarks are on those scapula. You have your humerus, which is also known as your arm bone. You have the head of your humerus, which is at the top here. Anatomical neck, which is this dotted line as you see on this picture here. You have your greater tubercle, which is right outside here. Your lesser tubercle, which is on the back side. Then you have some other tubercles as you go down, which are just more or less for muscle attachment points and all that good stuff. You have your intertrabecular sulcus, or your bicipital groove, which is right up in here. It's right in the front of your arm, where your bicep tendon runs down. It's like a little groove right in there. So that's just kind of where the tendon runs down. That'll kind of be important when we talk about like bicep injuries and all that other good stuff. So again, with the humerus, you have an angle of inclination, which is typically 130 to 150 degrees. It's just this matter of the angle from the angle is made up from the humerus bone and to how your head of your humerus is made, and that makes up an angle, which is called angle of inclination. So now we're going to start talking about the shoulder complex articulations, or the joints. You have your SE joint, which is right in front, right in the middle of your chest. It's right in the top of your sternum, and that little divot thing that you can feel like right under your throat is called your manubrium. And your sternal end of your clavicle articulates with the manubrium and the first rib there. As you can see in this picture, there's the first rib down here. There's your here's your sternum, and here's your clavicle, and this is where they meet, and they make this joint up a little bit. You have, let's see, anything of importance here. So as you can see, you kind of have all these little ligaments here that hold this stuff together, and then there's an articular disc, which is depicted here. It's kind of lifted off, which is kind of odd, but it's depicted here, and it's just like most other joints. There's some kind of articular disc in there that kind of do some shock absorption and kind of help out with the joint itself. And then you have your interclavicular joint, or ligament, which is right here. This kind of keeps both ends of your clavicles kind of in place and together there. And then we'll talk about SE joint sprains and injuries later on, and all that good stuff. So just the SE joint is articulation between the sternum and the acromion and the first rib. We got the AC joint, which we talked about briefly already, the acromioclavicular joint, It's made up of the acromion and the clavicular. Pretty simple to break down the name here. Again, there's an articular disc in between. It's right up in here. You have superior and inferior AC ligaments. Pretty simple. Superior is the one on top, inferior is the one on the bottom. And then you also have these coracoclavicular ligaments, which are right here, which you break it down from the coracoid and the clavicle, or the clavicle, which is the coracoid is right here off the bone, and it's just these two fans of tissues there. These are important when we talk about AC joint sprains because they're all involved here, and then as the grading system for AC joint sprains breaks it down, it depends on which ligaments are involved. Any questions on those first two joints? Good, pretty straightforward. What do we got next? The glenohumeral joint, or also known as like what everyone calls their shoulder, pretty much. It's made up of between the glenoid, gleno, and humerus, which is humeral. The glenoid is this small piece off of your scapula that we couldn't really see in those first two pictures. You kind of have to look at it on an angle. It's this small circular shape that the humerus kind of sits on. It's a ball and socket joint similar to your hip. However, this is kind of more like a golf ball on a tee because the glenoid's kind of small and the humeral head is kind of large. So it literally looks like a golf ball on a tee because there's not that big of a space for it to move. The humeral head is also, so it's like 3 to 4 times bigger than the size of the glenoid fossa where it's supposed to sit. And then you have surrounding this is that your shoulder labrum, which can be injured, and we'll talk about that when we go over injuries and all that good stuff. But you have a lot of motion with your shoulder. You can move it in all degrees of motion, kind of like your hip. And same thing with your hip. When most things in the body, if you increase mobility, you lack or give up stability, and if you increase stability, you lack mobility, kind of deal. So it has all kinds of. Do I have another slide on the motions? No. Okay. So the motions are pretty straightforward. Well, not straightforward. There's a bunch of all kinds of fun stuff. It can go flexion, which is just straight up. Extension, which is going back. Abduction, which is going out to the side. Adduction, which is coming back down to the middle. You have horizontal abduction, which is coming out this way in a horizontal plane. Horizontal abduction, coming back in. And then you have internal and external rotation of your arm. All that makes sense? Then you have the labrum, which I kind of said it covers the rim of that glenoid fossa there. It kind of acts as like a little bit of a wedge, so it kind of helps keep the suction of the humeral head in the joint there, so it doesn't pop out. Although it does pop out more than likely because of, like I said, it's really mobile, so there's lack stability. So then you have your ligaments or your capsule, which is, I guess this kind of does it justice. This kind of general overview of all this stuff around your shoulder. It's just a joint capsule like everything else. It's very loose and weak. Then you have other ligaments that I'm not going to hold you very much responsible for. However, the glenohumeral ligaments are the ones that are pretty straightforward, that they go from the glenoid to the humerus. You have a superior, inferior, and middle. So, best way to describe it, so the superior one prevents your arms, as you can see, it's kind of up top here. It prevents your arm from coming forward when you're kind of sitting in a normal position. The inferior glenohumeral ligament, it kind of acts like a hammock. It's kind of loose when you're kind of like this, but when you lift your arm up, it gets taut, so your arm doesn't slip down. And then you have your middle, which doesn't let you, and it prevents anterior translation as well, so it doesn't let you kind of come forward because they're both kind of up here, and then you have the one underneath. And we'll talk about those a little bit more when it comes to actual injuries and stuff and how they affect instability and all that good stuff. And then we have the posterior capsule, which is just this loose structure in the back of your Back of your shoulder, a lot of people have rotator cuff issues or anything. Their posterior capsule is really tight. So it gets tightest when you internally rotate and adduct your arm. So when you're kind of like this or even like this, that posterior capsule gets stretched out a lot and it gets really tight in there. And a lot of people, mostly throwers, will have a lot of issues with this and could develop what's called GIRD, G-I-R-D, which is glenohumeral internal rotation deficiency. So that's just something that can be caused from a tight capsule. So you also have a scapular thoracic articulation. It's not really a joint because there's no bone-on-bone contact. It's just this, your thoracic spine is here and your scapula is here, and these things glide on each other and they move as you move your shoulder around. I'll show you I have some videos on when we go over injuries and stuff of scapular movement and how it kind of changes with it and how the scapula move and all that good stuff. But someone with poor scapular thoracic movement will have what's called medial winging, which is this inferior angle of this scapula will kind of pop out. And I don't know if you've ever seen someone kind of like wing their scapula out and it kind of sticks out real far. It's because they have weak stability of their shoulders. We're not going to be responsible for that coracoacromial arch stuff. Then you have bursa, similar to the other joints in the body, like we talked about. You know, knee bursa, ankle bursa. It's this fluid-like structure that kind of layers and acts like as a lubricant kind of to the joint, and you can get these inflamed, which we'll talk about the bursitis of the shoulder in a little bit. It basically is just there to reduce the friction between two things. It separates the supraspinatus tendon and the head of the humerus from the inferior acromion, coracoid process, and coracoacromial ligament and deltoid. So that's why it's kind of sitting here. So as you can see, this right picture, it's still you're right on that side. This deltoid bursa or subdeltoid bursa is under the deltoid, and it kind of keeps the deltoid off of these muscles here. And same thing for this acromial, subacromial bursa. It keeps the muscles here off of the supraspinatus tendon, which is one of the rotator cuffs. So your axilla, which is also known as your armpit, is made up of, it has four borders. The anterior border, which is the front, is your pec major, or your chest muscle here. As you can see, it's in the front here. You have your lateral. The lateral structure would be your biceps and triceps and humeral shaft. It makes up the outside. The medial border, which is your ribs and serratus anterior muscle, and then you have your posterior border being your lats or latissimus dorsi and your teres major. So now we're going to talk about the muscles of the shoulders. We're going to kind of go over them in groups because there's a bunch of them, and they all kind of are particular in certain things, especially when we go over pathologies of injuries. They're all going to have their own like kind of important meaning to the certain injuries and all that good stuff. So we got your levator scapula. So right now we're talking about scapular muscles going forward. These are all scapular muscles that attach to the scapula, which is pretty straightforward if you break it down. Scapular muscles attached to the scapula. You have your levator scapulae, which is in charge of scapular elevation and retraction. So it kind of brings your scapula up and it retracts it back. Your rhomboid major. So you can see here, it's these fans of colors here, and then so this muscle is primarily responsible for, I guess, is it broken down? No, it's not. That's what I thought. Also responsible for retraction and downward rotation. So it rotates. As you can see, it's kind of angled here, so it causes this. So imagine this will actually rotate out when you move your shoulder, and it causes downward rotation by pulling on these fibers here to make it go back down when you're moving your shoulder around. You got your upper trap, which is, most people know what your traps are. It's your neck muscles here, responsible for shoulder elevation, retraction, and rotation to the head side to side. Also, lateral flexion of the head. So you can't really, I mean, you can't injure this kind of, but just so you know what's going on there with the motions of the trap. Then you have your middle trap, which are the middle fibers of this big triangular or diamond-shaped muscle. The middle traps are primarily used for retraction of the scapula. Then you got your last ones, which are your lower traps, which are responsible for scapular depression, retraction, upward rotation. Any questions with, oh, well, you got two more, I'm sorry. You got your serratus anterior, which is also known as your punching muscle. So it does scapular protraction, so from here to here, that's all that muscle does pretty much. And it has different fibers, as you can see it's kind of broken down at the bottom here. The lower fibers are responsible for the protraction, upward rotation, and scapular depression, whereas the upper fibers help with scapular elevation. But I primarily care about protractions with the serratus anterior. It's kind of its big job. And then you have your pectoralis minor. It sits underneath your pec major, and all this does is helps with protraction, which is going forward. A lot of people in today's society have tight pec minors because everyone's always like this, texting, looking down, sitting in chairs all day, driving their cars, or they're stressed and they just hunch over, or they just have bad posture. So this can cause a lot of things. We talked about this when we talked about the thoracic outlet syndrome. This can pinch on some of the blood vessels going into the arm and cause numbness, tingling, cold sensation, and poor blood supply to the hand because of this muscle being too tight. So those are it for the scapular muscles. So again, pec minor, we have the pec minor, serratus anterior, lower, middle, and upper traps, rhomboids, and levator scapula, or scapulae for the scapular muscles. So now we're going to talk about the glenohumeral muscles, which go across and move the joint of the glenoid and the humerus. Your biceps. Everybody pretty much knows what your biceps are. It's like one of the most, I don't know, it's got its own emoji pretty much. So it's out there. Everyone kind of knows what it is. So most people know it as, you know, it's your elbow flexor. It flexes, but it also does straight flexion of the shoulder as well. It's called bicep, bi meaning two, meaning it has two heads. And as you can see here, there's a short head that goes right into this coracoid process, and a long head that goes right back and around through that bicipital groove and attaches to the shoulder labrum. And it goes all the way past your elbow and attaches onto the radial tuberosity on in your forearm. I got some pretty cool videos of people tearing their biceps coming up, so we'll see those pretty contracted in a little bit. Your coracobrachialis is a shorter muscle. It is technically the is this? I always get this mixed up. Yeah. This is the prime flexor of the shoulder, because that's pretty much all it really does. It does do a little bit of adduction, horizontal adduction, but pretty much it just does this flexion motion is like its main thing. Because, you know, we talked about the bicep. It does shoulder flexion, but it also does elbow motions as well. You have your pectoralis major, which is, you know, your big pec muscles. As you can see, it kind of goes from all the way here all the way to here. It's a very large muscle. It has upper fibers and lower fibers, but it's pretty much primarily used for glenohumeral adduction, so coming across and bringing down, and then also internal rotation. It helps internally rotate a little bit. So that's kind of when you're doing a push-up, you're kind of pushing forward, doing that horizontal adduction motion, which is activating your chest. You have your anterior deltoid, which is just your deltoid, is your shoulder cap, if you will. And these primarily, well, the anterior fibers, if you can kind of see how they run, you can kind of assume what they do. So you tighten these up, it's going to bring your shoulder up, and it also helps with just horizontal regular abduction of the shoulder as well. We have your middles, which is pretty much straight in the middle, and this is primarily the only thing it does is glenohumeral abduction. So it just brings your arm out to the side. Then you have your posterior. It does horizontal abduction, bringing your arm back, and extension. So So basically, if you just cuff your or cap your shoulder, front muscles go up, middle muscles go out, back muscles go back. Pretty straightforward and simple if you just think of it in an anatomical position. And if you shorten the fibers, what would happen? Then you have your triceps, which again is in the back part of your arm. It is a primary elbow extender and shoulder extension, or extender rather. And again, tri for 3 different heads. It has a long head, a lateral head, and a medial head. Then you have your lats, or latissimus dorsi. It's this big fanned muscle that attaches all the way down into your lower back here, and its primarily job is for glenohumeral internal rotation and adduction. So you're internally rotating and adducting to your body. That's why when you do pull-ups and stuff, you're kind of in an internal rotation and you're adducting, bringing your arm down back to your side. Then you have the teres major, which is also known as the lat's little helper, because it pretty much does everything that the lat does, but it's much smaller, and it just kind of helps give an extra force there and kind of helps pull in a little bit more. Okay, so we got, what is this video? I always forget what videos I put on here. Oh, this video is really cool because it's in 3D and stuff. So as you can see here, I don't think there's any voiceover, but it goes over the muscles of the rotator cuff. It includes the bicep tendon too, but I don't really consider that a rotator cuff. But as you can see, kind of get a little bit better appreciation for these muscles and how they sit, and how the glenoid, the humerus kind of sits in there. So if we pause, actually go back a little bit. We pause that right here. We can see you have your infraspinatus here, your teres minor, and then you'll have your subscapularis in the front, and then up top here is your supraspinatus. Let's see if we have any other good looks at this guy here. So this is your supraspinatus, which sits in that supraspinous fossa of your scapula, which we talked about a little bit. And you can see the red is where the muscle sits primarily. What else we got? And then this blue that they're showing too is that bursa we talked about. So it's just kind of putting it all together, kind of getting to see what's going on here. So then we'll talk about, what really is going on with these muscles here in a second. So you have your supraspinatus. So you can see here it's very similar to that 3D image we got to see. This primary job for this muscle is to initiate shoulder abduction. So from here to about here is where this muscle is firing. So you have to come all the way out here, and then once you get past here, your deltoids kind of take over and get you the rest of the way up. Infraspinatus is one of the external rotators. As you can kind of see, it kind of wraps around the back part of this, the humerus. So imagine if you tighten these up, it's going to make your shoulder go backwards. And then you have,
This is the back?
yeah, it's looking from the back. Your teres minor, which is kind of doing the same thing. It just attaches to like that lateral border of the scapula there, and it does the same exact thing. External rotation, and they also do stabilize the humeral head in the socket. And then your subscapularis, so now this is looking at from the front. They kind of just took the rib cage out of here, and this is that muscle that sits in the front. And this is the only internal rotator, so it's responsible for internal rotation, along with your chest and everything else. So to remember those, a lot of people say your rotator cuff or the sits muscle, S-I-T-S, for supraspinatus, infraspinatus, teres minor, subscapularis. A good way to remember which muscles are the external rotators is, think of like an exit sign, right? EX, external rotations, IT, I for infraspinatus, T for teres minor. Kind of how I learned and kind of how I remembered the external rotators of the 4 rotator cuff muscles. Alright, and then we're not going to go into crazy shoulder mechanics, But quickly over for throwing mechanics, because it's pretty much all into the shoulder, because a lot of the injuries we're going to talk about are throwing athletes, of most people who get hurt in the shoulder. Other things are traumatic and happen, but you know, a lot of chronic stuff, labral tears and all that stuff happens from just throwing. So you have your basic, which is the wind-up. I'm sure everyone has seen someone throw a baseball at one point in time, and that's like the ideal throwing mechanics. It's a little different from throwing a football or javelin, all that other stuff, but this is like the go-to for throwing mechanics. You have your wind-up. It begins with the step back with the front foot, ends with the front leg gets to maximum height. As you can see in this picture here, it gets to the maximum height there, and that's when it stops. Once the wind-up stops, you go right into a stride phase where you start loading that back leg and you start striding forward. This ends as soon as that foot lands on the ground. The stride phase is over. Arm cocking phase is when your arm comes back and you're literally cocking it up, ready to go. This starts when your foot touches the ground and your pelvis starts to turn, and it stops once you reach as far as you can go back, external rotation. Once you stop there, it goes to the next phase. Arm acceleration. Pretty straightforward. Your arm starts to accelerate forward. It starts when you hit maximal external rotation and stops when you internally rotate. Then you have your follow through or your arm deceleration. And then this starts right when your arm is completely internally rotated and ends when you regain balance. So a lot of people have funky follow throughs, and some pitchers fall off to the side or they do some weird thing with their leg or something like that. But if you're not following through well enough, it could, you know, put a lot more stress onto your arm. Pathomechanics. So you can have a lot of issues. You know, you can have a tight posterior capsule, so you don't get that internal external rotation of throwing very well. So you can kind of get issues there. You can have external, excessive external rotation, which causes injury to a prone shoulder because you put yourself in a vulnerable position coming back this far. Your shoulder wants to pop out forward going that way. And then the repetitive stress of all this motion can kind of wear and tear on that bicep tendon that attaches to your labrum, causing some fraying and decaying of that labrum, and it kind of gets wonky in there, and then you'll have labral issues going forward. Impingement, you can do, I don't have anything in here. Oh, it's just pretty much poor rotator cuff function, and that supraspinatus gets really tight, and you just feel this aching shoulder pain because everything is just so tight and you don't have any room, and anytime you cross your body or do anything, your rotator cuff gets impinged a little bit. So that's it for those.